Good morning, everyone. Thank you so much for joining us on this beautiful Friday morning. I think many of you know me, but in case you don't, you probably recognize I'm not Yuan. So I'm Catherine Gao. I'm a pulmonary critical care physician scientist. I'm Associate Director of our Center for Collaborative AI Healthcare here and working to help out with this AI forum for health. So today, I'm absolutely delighted to welcome our speaker, Dr. Siva Bhavani. He's a pulmonary critical care physician scientist at Emory University. So Dr. Bhavani completed residency at the Baylor College of Medicine and then fellowship in pulmonary critical care just across town at the University of Chicago. His research centers on identifying treatment-responsive sepsis subphenotypes by applying machine learning algorithms to just routinely available clinical data. His work has been published in numerous top journals, ranging from JAMA, Intensive Care Medicine, AJR, CHEST, so many different things. He's received tons of funding, including from the American Thoracic Society, NIH K23, and then more recently, the Kaiser Permanente AIM High initiative for his PRECISE trial, which looks at whether AI algorithms can actually help us guide IV fluid choice in sepsis patients, so a potentially really high impact, low cost intervention. Dr. Bhavani's vision is to translate machine learning algorithms developed in his lab from paper to actual practice and evaluate the implementation effectiveness of these algorithms in really guiding precision treatments and improving the outcomes of critically ill patients. I've had the pleasure of getting to know Siva over the last few years, working together on ATS initiatives and the CLIF Consortium. He's really an amazing physician scientist, and we're so lucky today to have him today as a speaker. So without further ado, please join me in welcoming Dr. Siva Bhavani. Thanks.
Thanks so much, Kathy, and thank you for giving me this opportunity to present here. So I'll be presenting precision medicine and sepsis. And hopefully everyone can see my slides and everything is working out okay. So I'll be talking about sepsis and AI algorithms in sepsis and precision medicine in sepsis. But before we jump into that, I wanted to start with a broader topic, and that topic is randomized controlled trials. So randomized controlled trials are the cornerstone of how we evaluate treatments and interventions in medicine. It's been the gold standard for over 50 years on how we actually make causal inference on whether a drug is effective or not. So patients with some disease or some syndrome are randomized to getting a drug or getting a placebo. And through this process of randomization, we're able to make that causal inference and have a sense of the counterfactual of what would have happened if they didn't get the drug. So that's been a mainstay in medicine on how we evaluate drugs and devices. But there's a question that's been emerging in the past couple of years, and that question is in the AI world. Do we need randomized controlled trials of AI algorithms? Do we need to follow the same framework where in order to make causal inferences on whether AI algorithms are effective in changing patient outcomes, do we need a randomized controlled trial where patients are pretty much randomized to either getting the AI algorithm or a placebo? Do we need that same framework? And there's two extreme answers to this question. One extreme answer is to say every single AI algorithm has to undergo a randomized controlled trial before clinical use. That extreme answer might hamper progress because randomized controlled trials take months to years. So if you're going to have to wait months to years for every single algorithm before the next step of clinical implementation and clinical use, that might hamper progress. There's the other extreme that says that no AI algorithms have to have randomized controlled trials before you put them to clinical use. And that's also, an extreme answer that could cause harm. And it could cause harm because there's lots of unintended consequences with AI algorithms. And we need some sort of evaluation framework in order to figure those out. But if we look at the current state of AI in healthcare, we're much closer to this latter extreme. We're much closer to the extreme of there being no randomized controlled trials of AI algorithms. If we look at the space of AI in healthcare, there's thousands of algorithms out there. Every week on PubMed, you're going to see several new algorithms predicting X or Y in disease X and Y. And so you have so many algorithms out there. And out of those algorithms, there's hundreds that actually have FDA approval. So you have this huge space of algorithms out there, but in the US, there's only been 27 randomized controlled trials of AI algorithms at the time of this paper last year. That number is probably increasing, but it's still a vanishingly small number in the entire context of thousands of algorithms and hundreds coming out every year. So the question is, do we need more RCTs of AI algorithms? And there's this quote in the data science world: all models are wrong, but some models are useful. And the past decade, we've really been focused on whether models are right or wrong. How right is my model? How accurate is it? What's the AUC? What's the sensitivity? What's the specificity? So we've been focused on model-centric outcomes, but we haven't been focused on the second part: are these models useful? And for an AI model to be useful, it has to be able to change clinician behavior. And it has to change clinician behavior in a way that actually impacts and improves patient outcomes. And I would argue that the best way or the most robust way to test this pathway from AI model to clinician behavior to patient outcomes is through a randomized controlled trial. So the objectives of this talk are going to focus on sepsis, and it's going to focus on sepsis subphenotypes. So first, I'll talk about what are sepsis subphenotypes and what is the rationale behind investigating and looking for these subphenotypes. Next, I'll move on to using AI to discover these sepsis subphenotypes. And finally, I'll circle back to the randomized controlled trial as a way to actually evaluate subphenotyping algorithms. So sepsis is a dysregulated response to infection that results in organ dysfunction. It's a severe disease, just by definition. I mean, all of us get infections, whether it's the common cold, the flu, COVID-19, a bacterial infection. But at the point when your infection lands you in an ICU with organ damage, we kind of generally have a sense of that as being sepsis, a very severe response to infection. It's responsible for over 300,000 deaths in the US annually, $60 billion in annual hospital costs. And worldwide, it's responsible for 1 in 5 deaths. So sepsis is a huge public health emergency. But in addition to being severe, it's also a very heterogeneous syndrome. So just by definition, a dysregulated host or patient response to an infection. So there's a huge diversity in the type of patient that's going to get an infection, huge diversity in the type of pathogens causing infection, which results in this really complex syndrome that we're kind of calling under one umbrella term. Even within pathogens, you have viral, bacterial, fungal organisms. The same bacteria causing an infection in the urinary tract versus the lungs is going to present differently. So really heterogeneous syndrome. And to illustrate that a bit further, here we have a 25-year-old male, no medical history, and he's admitted with a viral pneumonia secondary to influenza A. He presents with high fevers, an elevated heart rate, and an elevated white blood cell count. And he develops kidney injury. So this is a patient presenting with an infection, and he develops organ damage secondary to the response to the infection. So this patient has sepsis. On the other conceptual extreme, you have a 72-year-old lady with congestive heart failure, chronic kidney disease, and she is admitted with a urinary tract infection secondary to E. coli. She presents with normal body temperature, a low white blood cell count, and altered mental status. So she has an infection, organ dysfunction, so she has sepsis. Both patients have sepsis, but just from a brief clinical vignette, we can tell that these are two very different types of sepsis. These patients are probably going to have very different trajectories, very different prognoses, and they probably respond differently to different treatments. But right now, both of these patients get the same treatment. And of course, the source control and antimicrobials are targeted towards the bacteria or the organism causing the infection. But everything else we do for sepsis is standardized supportive measures. It's standardized IV fluids, vasopressors to support the cardiovascular system, supporting the respiratory system, supporting the renal system. So it's all standardized supportive measures, but there's no precision targeting of sepsis management. And over the past 30 years, there's been over 100 clinical trials investigating dozens of different medications in patients with sepsis. And at the end of the day, all these trials end up being negative or shortly thereafter proven negative. And that's probably because we're enrolling both of these patients. Conceptual extremes of sepsis are being enrolled into these clinical trials. And some patients with sepsis might benefit from the treatment being tested. Some patients might be harmed. And when we group them all together in this clinical trials, we get a negative result. We get a null result. So that's the brief 5-minute explanation behind why we look for sepsis subphenotypes. What we want to do is break apart this clinically heterogeneous syndrome of sepsis into clinically relevant subtypes, or what we refer to as subphenotypes, because that could be the pathway towards a precision medicine approach to sepsis. What we want is a world where sepsis subphenotype A gets treatment A and subphenotype B gets treatment B. So when I got started on that path in research towards sepsis subphenotypes, what really intrigued me was body temperature. And the reason I was intrigued by body temperature is because it's one of the most clinically apparent heterogeneities that we notice about patients. When a patient has a fever, that's sometimes the first trigger to think, oh, maybe they have an infection. But lots of patients with infection do not present with fevers. They might even present with low body temperatures. And it's just something so universal. Even outside of the hospital, when we get sick, we check our temperature. It's frequently obtained. In patients in the hospital, we check temperature literally every 4 to every 8 hours in every patient in every hospital around the world. So it's just this universally available, frequently obtained measurement that's actually objective. It's actually intimately tied to your immune response to an infection. So it's possible that it can actually be informative to what your immune response to an infection is. This is an example of one patient's temperature measurements over the course of a couple of days. So there's a lot of data here, but in clinical practice, we don't actually use all this rich longitudinal temperature data. We take all this rich dynamic temperature data and boil it down to a static dichotomous variable of, do they have fever or do they not have fever? And that's how we use it clinically. And in fact, we probably haven't changed how we use it clinically for the past 150 years. Even the most things we know about temperature actually come from Dr. Carl Wunderlich in the 1800s, who wrote the book on temperature and diseases in 1868. And in one line in this book written in 1868 comes one of the most famous numbers in modern medicine, the threshold of 38 degrees Celsius. So it's just these old thresholds that we have kind of stuck with us. And so this patient in this example doesn't meet this semi-arbitrary clinical threshold for fever at 38 degrees Celsius. So all of this data goes to waste. So my question was, can we actually leverage all this longitudinal temperature data? And can we leverage this longitudinal temperature data to identify clusters of patients who follow distinct temperature patterns over time? And could that lead us to different treatment strategies for those patients? So that led to our work identifying novel sepsis subphenotypes using temperature trajectories. So in this work, what we did was we took patients who came to University of Chicago presenting with suspicion of infection, and we looked at their first 72 hours of temperature measurements. And this was the training cohort, and we had the validation cohort at Loyola University where we did the same thing. And we applied group-based trajectory modeling. So group-based trajectory modeling is a time series clustering algorithm that clusters patients who are following similar trajectories of a variable over time, in this case, temperature. So it takes all the temperature data and identifies the polynomial functions that best describe the underlying data. And so what we found was that a 4-group quadratic model fit best. So temperature as a quadratic function of time from presentation to the hospital. We call the 4 groups hyperthermic slow resolvers in orange. So these are the patients who have elevated temperatures coming in, relatively elevated temperatures coming in, and stay relatively elevated through the 72-hour period. Hyperthermic fast resolvers in green, who have similarly elevated initial temperatures, but effervesce over the 72-hour period. Normothermic patients in maroon, and hypothermic patients in blue. So these temperature trajectory subphenotypes had distinct clinical characteristics and very different outcomes, and they were predictive of things like mortality, needing renal replacement therapy, mechanical ventilation, vasopressor use. And the general takeaway was that these two extremes, the hyperthermic slow resolvers in orange and hypothermic patients in blue, did the worst. And the group that did the best were actually the hyperthermic fast resolvers. And so more interesting for us than the prognostic implications was, whether this could actually reflect the underlying biology or the immune response to the infection. And maybe these extremes, the hyperthermic slow resolvers and the hypothermics, were maladaptive responses, while the hyperthermic fast resolvers was an adaptive response to an infection. Since this work, we've published on the biological correlates of these temperature trajectory subphenotypes, initially in smaller cohorts with patients with septic shock and Staph aureus bacteremia. And what we found is that these temperature trajectory subphenotypes reflect distinct biological profiles, distinct cytokine profiles. And we've replicated this in much larger cohorts as well, most recently in a cohort of over 3,500 patients with suspected infection, where we found that these temperature trajectory subphenotypes, again, had these consistent findings of these biological patterns. So the thing that excites me the most about the temperature trajectory work is how reproducible it's been by our group and other groups as well. We've replicated it at multiple institutions and done this work on patients with sepsis, septic shock, COVID-19, neutropenia, and others have done this work in pediatrics as well. And most recently, we've replicated it thanks to the CLIF Consortium across 9 institutions and over 100,000 critically ill patients. So the CLIF Consortium is a common data format, which allows us to validate at much larger scales without having to share patient data. But to me, that's the most exciting thing about temperature trajectories is just how generalizable and reproducible it's been. The other thing that is appealing to me is the scalability of it. You don't need any esoteric biomarkers. All you need is a thermometer. And the model itself is 12 numbers, or 14 numbers technically. And so it's a very potentially scalable model. And the third thing is it's biologically plausible. In multiple biological studies by our group and others, we've shown the biological correlates. What we haven't shown yet is whether it's actually useful. Because for this model or any model to be useful, it's not good enough that they represent distinct biological entities. Those distinct biological entities, then we need to show respond differently to different treatments. And so that's the gap that we haven't bridged yet, which again is the goal of these sepsis subphenotypes. Again, the goal is that subphenotype A benefits from treatment A, subphenotype B benefits from treatment B, because we want the precision medicine approach to sepsis. So this led to my work on my K23 on vital sign trajectories. Again, it was the same framework. What are the data that's available in every hospital around the world? So temperature, heart rate, respiratory rate, systolic, diastolic blood pressure. And again, looking at trajectories. So instead of looking at a static snapshot, can we look at the trajectories of these measurements in a shorter time window, which might make it more useful for initial therapies itself? So we looked at the first 8 hours of these measurements. And this work was done at Emory. So the training data was data between 2014 to 2017, and the validation data was between 2018 to 2019. Again, we applied group-based trajectory modeling, but this time it was multi-trajectory modeling. And so each subphenotype, instead of being represented by a single function of a variable over time, they're represented by a set of 5 functions, one for each variable as a function of time. And we found that the 4-group model fit the data best. And we called these groups Group A, B, C, and D. And so these are the general patterns of the groups that you see here. On the left is the training data set, and on the right is the validation data set. So what we found again is that these groups represent distinct clinical characteristics. They have very different lab biomarkers, and they have different outcomes. But again, the whole goal is not just prognostic enrichment. The goal is that whether or not these groups actually respond differently to different treatments. And so in order to test that out, whether they can actually respond to different treatments, we went back to a trial published in the New England Journal of Medicine by Semler et al., the SMART trial. And this was a trial that was a cluster randomized trial that randomized patients to balance crystalloids versus normal saline. In the trial, they didn't find any mortality difference between the 2 groups. But our question was, if we go back to the trial data and we look at the trial patients and classify them using their vital signs into one of our 4 groups, could we actually see a difference in treatment effect across these groups and within these groups? So what we found was that there was significant heterogeneity of treatment effect. And maybe the reason there's no mortality benefit overall is because each of these groups might have slightly different responses to the treatment. And there was one group that actually had a significant mortality benefit from balanced crystalloids compared to normal saline. So when we found this, we were very excited, but there's another quote that I love in the data science world. If you torture the data long enough, it'll confess to anything. So, if you split the data enough, are we just going to find some, arbitrary split of sepsis that happens to show this pattern? And so one of the things we thought about was, well, is this just an artifact of the computational approach we're using? Or is there some truth to the underlying physiological trajectories in the first couple hours of patients who are showing up with infection? So what we did was we decided, let's just use a completely different approach instead of group-based trajectory modeling. So we used dynamic time warping, which is an algorithm that quantifies distance between two sequences. And so it aligns the sequence through temporal warping and gives you a distance matrix. So once you have the distance matrix, then you can use traditional clustering algorithms like hierarchical clustering or partition around medioids to actually get the resulting clusters. And so when we did this, what we found was that regardless of the approach, the actual patterns look the same. There's obvious differences like, so group-based trajectory modeling, you have to specify a polynomial shape. So you have to say linear, cubic, quadratic, and test all these different shapes out. So it's going to have a specified shape, which, when you have a distance matrix and then apply a clustering algorithm, you're not going to restrict it to any shape, but you still get similar patterns, which was really surprising to us. And most importantly, we found the same treatment benefit, the same directionality, and the same group D getting a mortality benefit from balanced crystalloids when we applied these algorithms to the SMART trial data. And the reason why this finding was exciting to us is because intravenous fluids are the most common treatment given to patients in the hospital. Every year, 30 million people receive IV fluids. So if you ever show up in a hospital, you'll probably get some amount of IV fluids. And when we talk about IV crystalloid fluids, there's these two major options. There's balanced crystalloids and normal saline. And the SMART trial is one of the trials that looked at the comparison between these two fluids. But over the past decade or so, there's been 13 randomized controlled trials that have randomized 35,000 patients to getting balanced crystalloids or getting normal saline. And we still don't have an answer to which fluid is better than the other. And that's probably because the right question probably isn't which fluid is better than the other. The right question is probably which fluid is better for which patient. And so we think the right patient for balanced crystalloids is our group D patients based on our secondary analysis. So we wanted a way to actually test this out. And lucky for us, right around that time, Kaiser Permanente and Gordon and Betty Moore Foundation came out with the AIM High Call, which was calling for institutions that had an AI algorithm that they wanted to test prospectively and evaluate patient-centered outcomes. And so we were lucky to have this funding opportunity, and that is the foundation of the PRECISE trial. So the PRECISE trial is the Precision Resuscitation with Crystalloids in Sepsis trial. It's an EHR integrated, single-blinded, randomized controlled trial. It's EHR integrated, so the entire thing is happening in the background of Epic. So our algorithm is running in the background of Epic and automatically identifying group D patients. Again, that's the group that we think benefits from balanced crystalloids, and randomizing them to usual care or intervention. Okay. So what is usual care versus intervention? So under usual care, the clinician can order normal saline and there's no feedback from our algorithm. So this is pretty much the equivalent of a placebo arm in a drug trial. In the intervention arm, when the clinician orders normal saline, there's an EHR alert that nudges the clinician to choose balanced crystalloids instead, because we think balanced crystalloids will have a mortality benefit in this group. So EHR alerts. As a clinician, I know nobody likes EHR alerts. It's intrusive. It's just, it's not fun. But our whole goal in designing this alert is how do we make it minimally intrusive and maximally actionable? So this only fires when normal saline is ordered in an intervention arm patient. The alert announces that it's part of the trial, announces that there's a potential mortality benefit if you switch, and it gives you the option to switch to the balanced crystalloids. If the clinician wants to stick with normal saline, they have that option as well. So we tried to, really make it as minimally intrusive and easily clickable as possible. So the technical implementation of the algorithm, the trial itself, consisted of 4 parts. So the algorithm implementation actually ended up being one of the simpler parts of the trial itself. So getting the code base from R into Epic, so that we can actually identify the patients in real time. The other parts of technical implementation was building out the inclusion criteria. So again, it's EHR integrated. So there's no clinical coordinator checking patients whether they meet inclusion criteria, exclusion criteria. Everything is automated in the EHR. So we had to build out all the criteria. The randomization happens within Epic as well. And finally, of course, the medication alert we had to build out, which fires within Epic. So the sample size that's expected is 2,002 patients based on our power calculations. And we're enrolling across 6 hospitals. This time to enrollment needs to be updated, but it's going to be like 1 to 2 years. So the primary outcome is 30-day mortality, and the secondary outcomes are ICU admission, in-hospital mortality, and receipt of organ support. And I wanted to talk about the primary outcome of 30-day inpatient mortality. So again, here, what we're really doing is randomizing patients to get the alert, getting an alert to the clinician. So you can imagine, even in the intervention arm, you might have patients getting normal saline, even though we're trying to get the clinicians to choose balanced crystalloids instead. Because you can imagine the clinician could just disregard the alert or have a legitimate reason to order normal saline. So in order to really detect any outcome difference, we need to really separate these 2 groups, the usual care and intervention, in terms of the type of fluids they're getting. In order to do that, the alert has to be really, really effective in changing clinician behavior. And then, of course, that change in clinician behavior has to actually translate to an improvement in patient outcome. Since the alert was such a crucial part of our trial, we had a 3-month clinical education campaign where we targeted all 6 hospitals, the 6 emergency departments, the 17 ICUs, each of the individual department and ICU meetings, residency and fellowship programs as well, and sent an individualized email to every single ED and ICU clinician that might come across this alert. And the whole goal was that anyone who sees this alert is aware of the trial and the reasoning behind why we're doing this alert, why we're doing this study. So the progress on the study. So we had 9 months for the technical implementation, 6 months for regulatory procedures, and 3 months for the clinical education, all happening in overlapping periods. So with all that, the PRECISE trial launched June 13th of 2024. We had over 500 patients randomized through October. Unfortunately, the trial was paused in October because of the IV fluid shortage. So there was a national IV fluid shortage secondary to Hurricane Helene, which affected a plant in North Carolina, a Baxter plant in North Carolina, which was actually responsible for 60% of IV fluid bags across the country. But the good news is fluids are back across hospitals, and Baxter is back, and our trial has restarted as of last month. So I wanted to talk a little bit about the lessons that we've learned through the trial. The trial, I think, is unique in 2 ways. One is, of course, it's a trial of an AI algorithm, but it's also an EHR integrated trial. And these 2 things don't have to go together. So you could have a trial of a randomized controlled trial of an AI algorithm where you are enrolling patients and have a clinical coordinator, and it doesn't have to be automated through the EHR. And at the same time, you can have an EHR integrated trial that's not testing an AI algorithm. But when these 2 things combine, I think there's specific challenges that come with it. And one of the big challenges with AI algorithms and actually implementing them in real time is complexity equals less control over quality. And when I mean complexity, I'm not actually talking about the complexity of the functional form of the model, which I kind of initially thought would be the biggest barrier. So whether it's a simple logistic regression, if it's a neural network, it's not actually the functional form of the model that I think is the complexity that causes less control over the quality. It's actually the complexity of the input space. So our inputs, there's 5 inputs: temperature, heart rate, respiratory rate, systolic and diastolic blood pressure. But even with 5 inputs, we had to do over 100 chart reviews to figure out all the different edge cases where things weren't working properly. And the example I like to give is actually about temperature. So oftentimes in the ER, first, well, when the algorithm itself, since it only requires 5 inputs, we don't impute any values. We just wait for these values that are routinely going to be obtained anyways to be available before the patient is classified by the algorithm into a group. So the algorithm does not classify a patient unless they have temperature, heart rate, respiratory rate, systolic and diastolic blood pressure. But in the ER, we noticed oftentimes the vital signs are documented except for temperature, and there's asynchronous documentation of when temperature is actually listed. So there are patients who will have heart rate, respiratory rate, and blood pressure, but not temperature yet. And these patients were being classified into a group, which didn't make any sense so from our algorithm standpoint. So when we did the calculations behind it, we realized they were getting a 0 degrees Celsius for their temperature, which was not being done by our algorithm, but might be in the back end of Epic. So these are things that, if you imagine an algorithm with 100 variables, it might be more difficult to capture where something might be imputed or some transformation might be happening or some error in mapping might be happening to the input space. And so I think the more complexity you have in the input space, the less control you have over quality. This doesn't mean we can't do complex algorithms. It just means we need more quality control. And one of the things that I actually wish we did differently was in the testing phases to actually hire someone whose full-time job was to actually do chart reviews day in and day out, which ended up being my job. But so it's something that's really important that didn't occur to me when we were designing the trial. With EHR integrated trials, the same lesson applies. Complexity equals less control. And here it's the complexity, the inclusion and exclusion criteria. So with the inclusion and exclusion criteria, we tried to keep it simple and pragmatic. But even with that, with building these rules into Epic, there were so many edge cases where patients would be included when they shouldn't be, or would be excluded when they should be included. So this required a lot of, again, chart reviews to figure out all these edge cases. And so here, more complexity equals less control over quality. But here, more complexity might actually mean you don't want an EHR integrated trial. You want clinical coordinators on the ground actually figuring this out. So that's a balance that, it's probably very trial specific. So I wanted to circle back to the concept that we started with. So sepsis subtypes. So I called them subphenotypes, but in general, this concept is we're taking this heterogeneous syndrome of sepsis and breaking it down into clinically relevant subtypes. And when we think about how to do that, there's thousands of data elements to choose from. We use vital signs, but other labs use vital signs in labs. Others might just put everything in the EHR and subtype patients. Others use non-EHR data and biologically very relevant data like transcriptomics. So there's thousands of data elements that you could potentially choose from when you're subtyping sepsis. On top of that, there's hundreds of clustering algorithms. And if you're, even with the same set of data elements, if you use 2 different clustering algorithms, you might get 2 different sets of subtypes. So when you have thousands of data elements to choose from, hundreds of clustering algorithms to choose from, you have this huge universe of potential sepsis subtypes. And all that to say, there is no right way to subtype sepsis. There's no best way to subtype sepsis. And I think it really comes back to this quote that we started with. All models are wrong, but some models are useful. So of course, all sepsis subtypes are wrong. You're taking this artificially defined clinical entity and arbitrarily breaking it down into subgroups. So you can argue for the clinical relevance of these subgroups, but they're still wrong because it's an artifact of the systems, the computational approaches and the data that you're using. But the question really isn't whether it's right or wrong. The question is whether these models are useful. And again, for a sepsis subtype model to be useful, it has to change clinician behavior. And that change in clinician behavior has to impact and improve patient outcomes. And again, the most robust way to test this chain of this pathway is through randomized controlled trials. So do we need randomized controlled trials of AI algorithms? I think the right answer is somewhere in the middle of yes to all and no to all. And there's probably some AI algorithms where the best way to make the causal inference on whether they're actually going to be useful is through randomized controlled trials. But I'll say, even though not all AI algorithms require randomized controlled trials, all AI algorithms need patient-centric evaluation. And patient-centric evaluation requires a prospective evaluation that requires at least 4 minimal things that have been thought through for study design. One is, of course, the patient cohort that we're focusing on, really defining that patient cohort, defining the setting that we're testing it in. And then third, and potentially most important, defining the control group. Again, it doesn't have to be a randomized control group, but it has to be a well-matched control group where you can draw the causal inference on the counterfactual of what would have happened if the patient didn't get the AI algorithm monitoring their care. And then finally, a patient-centric outcome. It has to be a patient-centric outcome that's actually evaluated in this prospective evaluation for a patient-centric evaluation. And the reason for this is, I think the situation we want to avoid is 5 years from now, having our EHR ecosystems being drowned with dozens and dozens of AI algorithms, and we have no idea which ones are actually helpful, which ones are neutral, and which ones are harmful. And so we want to avoid that situation. And the irony isn't lost that this is an AI-generated image highlighting the dangers of AI. But the real danger is that we have a lot of things that we don't know if it's actually helpful or not. And it's worsening clinician behavior. It's hampering clinician decision-making. And so we're going to result in poor patient outcomes. And really what we want is AI algorithms that optimize clinician behaviors to improve patient outcomes. So thank you for the entire team that makes this possible, my lab members and collaborators, including the STAGE team, the CLIF Consortium, the entire PRECISE clinical team, the entire PRECISE technical team, Jace Overlay, Aaron Morrison, Don Mock, Caitlin Worm, Nevin Etter, who were the technical team that made the PRECISE trial possible, and funders as well. And thank you, Kathy and Yuan, so much for this invite. I'll take any questions that people may have.
Wow, that was such an amazing talk. Thank you so much. Please join me. I see the little clapping emoticons in thanking Dr. Bhavani for such a great presentation. There are so many things you said during your talk that just really resonated with me. The focus on patient-centric outcomes, the difficulties and trials and tribulations of designing a randomized controlled trial. I just can't imagine how much of an undertaking it's been. So thank you again so much for summarizing. It's so cool to see from sort of the beginning of your works and fellowship to how you've grown it and now really are crossing that like model to deployment cliff that a lot of models just kind of vanish in. So I really admire that about your work. Let me turn to the Q&A here to see some questions that have come through. So first of all, Anita in the Q&A just said customized treatment for each patient, light bulb moments. And I think that's exactly one of the key points and features of your work. I think it's so cool that you have chosen, again, this universally available vital signs temperature and sort of a similarly pillar treatment of IV fluid so that, you know, anything you find will really, really have such wide reaching ramifications. That's so cool. A couple of questions that have come through. There's some comments about, again, amazing work. One question is, if PRECISE is successful, what barriers to implementations at other health systems do you anticipate, and how might you think about overcoming them?
Yeah, that's a great question. So how would we implement it across multiple systems? I think one of the barriers is going to be the different EHR systems itself. We, very much targeted the implementation of this to Epic, and rolling it across other kind of EMR systems is going to have its own unique challenges. That being said, Epic is very popular. There's a lot of institutions that use Epic. But even within Epic, there's so many different instances of Epic. This is a very locally implemented version of our algorithm. And, I think even if PRECISE is successful, it's not a click of a switch to say that, okay, now it can be used across institutions. I really think that would take a broader work of how do we make this generalizable to all Epic instances. And then from the clinical standpoint, I think what might make it different is, or what might change whether it's actually effective or just a nuisance is actually whether people are like what type of fluids clinicians are already using. We've found that even over the past couple of years, clinicians have been switching over to balanced crystalloids, especially in our tertiary care hospitals. So we're already starting with a really high usage of balanced crystalloids. And so there's not much convincing even within a subgroup. And so that's another barrier in the sense of a barrier of efficacy might depend on the current clinical practices.
That it's like you read the chat already. A comment from Nelson who says, first of all, Siva, this was great. Can you speak to the sort of this cross contamination in the control group and sort of maybe in part due to your excellent education that you've taken as a part of this trial? Have you seen an increase in the use of balanced fluids, for example, nudging clinicians to consider it more often might change their usual baselines? You sort of hinted at that a little bit, if you would like to just expand on that.
Yeah, that's something we are concerned about. I mean, in our clinical education, we always try to make the caveat of this is not like saying use balanced crystalloids for everyone. Still use whatever you want to use. This is just if you get the alert, this is how you'd respond to the alert. That being said, I agree with Nelson that there's probably going to be a slow shift toward it because if you get the alert enough, you're just like, okay, whatever, I'm just going to start ordering balanced crystalloids. We haven't looked at that yet. But that is one of the things we're going to be looking at, whether the overall trends have changed, which have already been changing even pre-trial, but post-trial, if that just sped up already existing changes.
Great. Yeah, and I see your hand is raised. Please go ahead.
Thank you. Siva, great talk. And just I wanted to follow up on your perspectives about the RCTs of AI algorithms, because we know that AI algorithms could be self-evolving at a really fast pace. And the fact that it passed RCTs at a certain point doesn't guarantee that it's going to be as effective or as relevant as time goes by, and it could be changing like in years, actually in months, or maybe even sooner. So we know that in the medicine field, I think clinicians, they pass the board exam and then they do continuous medical education, and then after some period they're gonna need to repass the board exam. So do you think that something similar is gonna evolve for AI algorithms and passing RCTs? Maybe consider RCTs as the board exam, and in the interim of different RCTs, maybe you will have some mechanism for ensuring that the AI algorithm goes through the CMEs and stay relevant, stay effective. And just wanted to see what's your take on that fact.
I love that analogy. If it hasn't been written up yet, somebody should write up something that analogy. Um, but yeah, I actually think that's really important because like the RCT might give you again, a static glance of how the model performed over that period, but with everything that's changing and with updated algorithms that are also in the ecosystem, because whenever you're evaluating an algorithm, you're evaluating it in the current ecosystem of other algorithms. So a year from now, it might be that algorithm has also been improved, but also there's two other algorithms that are in the ecosystem that might change the way clinicians react to the output of the algorithm of interest. So I think it is important to have model monitoring. I haven't personally thought through what that would mean in terms of renewing CMEs for the algorithm and whether, but I think at that point, I think most people would agree that repeated randomized control trials and these extensive testing is probably not worthwhile and probably going to hamper progress. If you have an initial good evaluation framework, again, doesn't have to be RCT, but good prospective evaluation that shows improvement in patient outcomes, then I think the next CME credit should be of less intensity of expectations, but requires some amount of monitoring.
Yeah, sounds great. I'm definitely happy to further brainstorming and maybe materialize some of those thoughts with you and others.
Yeah.
Awesome. Some other questions that have come up in the Q&A. Anonymous Entity says, great talk. I learned so much. Can you talk a little bit about the IRB oversight consent issues and how you manage that for your randomized control trial?
Yeah, that's a great question. Our IRB did grant waiver of consent, which we in practicality had to have for an EHR integrated automated trial. The rationale for that was one, the SMART trial itself, which compared randomized patients to balanced crystalloids versus normal saline, had waiver of patient consent. So we kind of posited that we were one step back from that because we're not randomizing to one fluid versus the other. We're randomizing to an intervention that suggests to the clinician to give one fluid rather than the other. And the clinician has the final decision at hand. So that was the second important part. And then the third important part is both of these are still standards of care. These aren't investigational medicines. So whether you give balanced crystalloids or normal saline, it's, people have preferences, but it's hard to make strong arguments over it. So it was both standards of care as well. So that was kind of the arguments that we laid out for the rationale for waiver of consent. Which really didn't involve the AI piece as much. I'm not sure. I think it's going to be very institutional dependent how comfortable different IRBs are with these kind of decisions.
Yeah, no, I think you're really this type of trial, this type of algorithm, sort of these rapid changes around policy and software as a medical device, where the border for that is. I think we're just living in such exciting, unprecedented times where we're sort of pushing the boundaries of this. So I think it's super interesting to think, what counts as something that's sort of AI influence more so than sort of just a suggestion as a typical pop-up. So along that lines, Lauren in the Q&A asked, "Hi Siva, great talk. Are you applying this if you're applying this to patients in sepsis, what criteria are you using to capture that cohort? And do you have issues with multiple pop-ups from other sepsis best practice alerts that might sort of cross aims with your work?" Fascinating work.
Thanks for that question. For the pragmatic component of it, we actually just took a step back and said any patient with suspicion of infection. So just EHR, blood culture, it was very, very broad and pragmatic. So it's actually not truly sepsis, although we have secondary analyses focused on patients who then have confirmed sepsis. And the reason was we didn't want to wait for triggers that that would allow us to know through the EHR data that the patient has sepsis before this intervention is initiated. So we want it to be initiated as soon as possible, since IV fluids are often given within the first couple hours itself. As far as the other BPAs, we just like every system, we have our set of sepsis, pop-ups. Well, I don't think it interferes because we really tried to make it just attached to the medication itself. So again, this only pops up when normal saline is ordered. And again, I think that's going to be a big thing with these BPAs. Like, when should these be popping up? You don't want to know about a patient's sepsis when you open their chart. You want to know about it, I don't know when, but at some other point, at some other more convenient and useful point. So I don't think it interferes with that just because of the timing of our alerts.
Yeah, no, I think that just speaks to sort of how thoughtful you guys were when designing the intervention to really make sure that it's being delivered to the right provider at the right time and at the right moment to sort of be most convenient. So I think that's really cool. Oh, there is actually a more general question in the chats. I think this is one of the most exciting and dynamic Q&A sessions I think we've had. So that just speaks to, again, what great work that you've had and presented here. So in the chat, someone had asked if you would be okay with sharing your email and contact information possibly with the audience in order to, if they wanted to follow up with you and potentially collaborate with you further. So with that, if that's okay, I think a member of the team could just kind of list it in the webinar chat if we would have your permission to. Oh, there you go. That's
yeah, of course, happy to collaborate.
That's awesome. Yeah, I hope you don't get spammed with too many emails afterwards, just based on all the excitement that's here. There we go. Yeah, thank you. Another question that's come up, and I think this is always an interesting one, is about AI explainability. So you showed us sort of how the BPA pops up, but is there anything in your alert that explains kind of a little bit more about why you think this patient might, potentially particularly benefit from crystalloid because of like X feature or Y feature, just again to sort of unveil that sort of black box around AI algorithms?
Yeah, we thought about how detailed to make our alert. And we didn't do like A/B testing or anything, although there's a separate kind of a sub-study that we're looking at what would be preferential to clinicians. So we thought about this longer one where we kind of go into the details of how we found the benefit for this group. But we just felt like clinicians don't actually read alerts, which is like a sad thing to say, but the clinicians I felt like are so overwhelmed that even though we do think that explainability is important, at the time of intersection with patient care, I think it's more just like whether it fits into the workflow or not. I think explainability could happen off EHR, where in the clinical education campaign, you kind of go into the rationale for the study and like how we did the study to find this group that benefits. And we did some of that where we explained but it's not explainability at the patient level where we're explaining which features of their vital signs directed them to one group or the other.
That's super cool. And yeah, again, I think exactly like you said, the balance between, being helpful, but also not overloading the end user with too much information that they, don't need or want at that moment is really key. And I think again, there's so many of these interesting questions in designing again these newer interventions that are so different from the traditional RCT interventional trial that I think we're going to all be lucky and learn a lot from your experience here.
Yeah, people even brought up, should we just do an opt-out? Like right now it's an opt-in because they have to choose, yes, fine, I'll switch the fluids, or no, I'm going to stick with mine. What if you just cancel their order and it was automatically ordered, but then they have to go back? So, I mean, there was all sorts of like kind of like extreme pushes that were brought up, which might have been harder with the IRB to kind of sell that.
No, that's absolutely fascinating. I think you could write like a whole experience piece just about all the things you learned and exactly all these sort of design nuances that you've come up with along the way. Just adding to all your list of things to potentially do and work on. Someone had asked in the chat about sharing the slides. I do believe the whole session is recorded and will be shared on the IAM website. I think given to the webinar attendees. Meg or Eva, please correct me if that's wrong. So you will be able to go back and watch Dr. Bhavani's talk as many times as you like. I think there's a lot to be gleaned here. So again, what a fantastic talk from Dr. Siva Bhavani. If the audience again could just join me in a round of applause for a incredible body of work and again, really pushing the boundaries of new ideas and new randomized trials to really kind of study these interventions rigorously. I think I truly admire that. Again, yes, thank you. The slides and recording will be emailed to everyone who registered as well as posted on IAM's YouTube channel. Our next session will be on May 16th, at which we will be welcoming Dr. Xia Ning from the Ohio State University. So stay tuned for more details about that to come and registration link that will be made available in the near future. And yeah, thank you. I hope everyone has a fantastic Friday and a fantastic weekend. And thank you all so much for being here with us and for a really dynamic, engaged conversation.
Thank you all so much.
Thank you.